Hi. Hi, guys. Who's ready for tonight? We are waiting for a request from Dr. Berookhim. Wait, I just canceled it. Dr. Berookhim, can you do it again? I'm sorry. Hi, everybody. Hi. Okay. Hi, everybody. Albert Manopla, thank you for our plug. You're awesome. Hi.
Hello.
Let's wait another minute or two. It's only 8:01, and then we'll start. Hi, Ma. Everybody, this is Dr. Berookhim. He's our guest tonight. We're so honored. He'll introduce himself in a minute.
So is your mom on when you said hi, Mom?
Yeah, my mom's on. Guys, Dr. Berookhim is new to Instagram, so we have to teach him some tricks.
I see lots of hearts so far, so I think that's a good sign. I think we'll be all right.
We're up to 200 viewers in 2 minutes, so that's fun. Tonight's going to be awesome. So everybody text your friends last minute. Remind them to come on. We'll wait another minute or two for all the people putting their kids to bed and eating dinner. Guys, how awesome is Instagram Live? I think it's the best thing to come out of lockdown. Oh, hi, Mom-in-law. Are you in your office?
I'm at home. I'm at home. Yeah. I'm not wearing any clothes below here. So.
So that's the best thing about doing a live. You just have to wear a decent shirt, and then you can wear stretchy pants.
Exactly.
That's the fun part. There's no need to dress up. You can accomplish tons in pajamas.
That's right.
You got a shout out as the best actor.
I don't know if I warrant that, but I'll take it. Thank you.
I'm sure you do. We only bring on the best guys. Okay, another minute, and then we'll get started. Who's excited? Everyone excited? I haven't been on for a long time. Did everyone miss me?
Crickets.
Well, I miss doing it.
I think, yeah, there you go.
Fastest is excited. She's excited.
Yeah.
Oh, my husband's excited. Hi, Mar. Okay. All right, let's start. Should we start?
I think so, yeah.
Okay, so we're starting. So first of all, I want to just take a minute to thank everybody. After each live, every time we open up the conversation to a new topic, SBH Fertility gets a tremendous influx of phone calls. By sharing your with us and coming to us for guidance, you guys really motivate us to move forward. You encourage us to seek out the best doctors, as we have with us now, because we want to build our resources and our guides so that we can continue to help you. And you really push us to find new topics about topics that really have been silent for way too long, including and especially tonight's very exciting topic of male infertility. So I just want to numbers for a second because I feel like the data holds a lot of weight, and Dr. Berookhim will expand on it in a bit. 20 to 30% of couples going through infertility, it's male. Another 20 to 30% of couples going through infertility, it's male and female. So roughly half of all couples going through infertility have some kind of male component. That's not a small number. That's not a small statistic at all. And where are all? We don't hear from them. We never talk about it. And while women have begun to really speak more freely about it, men are very absent from this conversation. Pregnancy and infertility has largely been seen as women's issues, as we are the ones to either get pregnant or not pregnant. And when we go through infertility treatment, our bodies are really the ones that take the brunt of treatment. So resources for men are scarce. Like if you just think about sitting in the doctor's office, all of the family building pamphlets, really what do you see? You see mommy holding cute fat baby, playing with their feet, and you see like in terms of infertility, you'll see a woman in complete distress and her husband is like lovingly and tenderly holding her or hugging her and giving her support. And like society really overlooks the burden of infertility on men. We became blasé to it. And instead of acknowledging it, we stigmatize it. We stigmatize male infertility as being emasculating. And this may induce a lot of feelings of guilt and low self-esteem, shame and loneliness, partially due to the lack of resources and the shame in reaching out for help and finding them. So tonight we're going to start with resource number 1, which is an education. And I'm a firm more you know, the better off you are. It's half the battle. You are more intuitive to your own body and your own, you know when to visit, you know which doctor you need to see, and you know which questions to ask. So we are extremely, extremely honored for our education tonight to have Dr. Berookhim with us. So excited, and thank you for joining us.
Oh, it's my pleasure. And, you know, I think kind of dovetailing on what you're saying, you know, it goes beyond just kind of something that's out in the community, because the patients themselves very often feel this stigma in a very painful way. So it's not unusual for me to see a couple coming into the office. The wife is engaged and she wants to get everything going, and this is what's happening, and we need this and we need that, and the husband's just sitting there, his head's kind of down and doesn't want to talk. Or he comes in on his own and he doesn't really know much of what's going on, and it's kind of like, you know, let's just get this done and get it over with and move forward. And really the idea here is that the couple is one unit. It's not her problem, it's not my problem, it's your problem collectively. And so everything that we do is working towards that one objective of getting the couple to be getting to that endpoint that they're searching. Right. And if at the end of the day it's leading to a baby in arms, that's the objective, that's the goal, so we treat. And you know, whether that means we have to treat the husband, whether that means you have to treat the wife, whether it means you have to treat both, you're going towards that same goal. And I think once you put that goal in mind, then, you know, the horizons kind of open up and the shame falls away, because, you know, it's a medical issue. And that's really what we're here to fix.
So could you tell everyone just for a minute what kind of doctor you are specifically, and tell us a little bit about your field, why you got into it, just so we could get to know you?
Sure. Yeah. So I'm a urologist. Urology is a specialty that focuses in the field of the genitourinary tract. So we're surgeons. We focus in the treatment of kidneys, bladder, prostate, and then male organs. So kidneys and bladder are things that we share with women, and then the rest of it is going to be more male-oriented. In terms of why I went into this field, I think for me the main objective was, number one, there's a lot of surgery in it, so you know, I like working with my hands, I like doing delicate work like that. But I think the second element of it was really this fertility aspect of things, which was, you know, to take a couple and to help to bring life into the world is probably the ultimate in terms of reward. Wow. You know, if you look at a surgeon who removes a cancer in a 75-year-old person, yeah, you did something great. And yeah, that person lives another 5-10 years. But if you take a couple who's having difficulty and you have a hand in their eventual success with help from above, that's 85, 90 years of life times a few kids. You know, your reward becomes huge. And so it kind of dragged me in pretty quickly, I think.
That's amazing. That's incredible. So tell us, like, walk us through the first appointment. A couple comes to you. What does that appointment look like? What kind of questions do you ask? What do they ask? What kind of evaluations do you do?
So, you know, I think the beginning of it is kind of a little bit cookie cutter and algorithmic, meaning, you know, we're just trying to get some of the basic data. So when the couple does come in, they're often given a questionnaire, which will get pretty in-depth and in some cases can be sometimes embarrassing. But really the idea is to break down the borders fast, meaning we want to break the ice and get to the root of it because nobody's ever used to talking about this. And I think that the quicker that we can get this to be something that it's more clinical and medical rather than you're talking about bedroom stuff and other things of the sort, the better we are towards working towards that goal. Once we get through that, really the history consists of a couple of different questions. The first is trying to get an understanding of how long the couple has been trying. Has the wife undergone an evaluation? What testing has the husband gone through? What other medical problems does he have? What surgeries has he had? Does he take any medications? And then from there, we tend to drill down. You know, in childhood, were there certain diseases that they were exposed to? Are there certain medications that they take? And then we move forward with a physical exam thereafter.
Do you find it takes couples long to actually get to you? Do they usually see a woman's doctor first and then procrastinate until they see you?
You know, usually I'm seeing couples later in the process. So, you know, for the most part, the woman's doctor tends to be the gatekeeper. And it really depends on what that gatekeeper's ethos is and how they kind of approach medicine as to whether or not that patient will even get to me. Mm-hmm. So some doctors will send sooner. Other patients will come to me after 2, 3, 4 years of trying where they've been going to female doctor after female doctor, everything's fine, everything's fine, everything's fine, and then all of a sudden they ask for a test report, and by the way, your sperm count has been 5% of where it should be. And it's been like that for 4 years.
And from the beginning.
And yeah, nobody's ever sent them. So, you know, it's, I think we've done kind of a poor job as physicians and as urologists in terms of getting the word out to say, you know, the male factor is half of this issue. And, you know, it's been driven by business and it's been driven, you know, one of the greatest, most miraculous advances in medicine was the advent of IVF. Having couples be able to get pregnant where it was never possible before really moved everything forward, but it stopped the male factor evaluation cold because what it turned into is you need one sperm.
Right.
And since that time, research stopped, everything else stopped, and it's really on us to try to expand that and to move that forward.
So what kind of evaluations do you start with after the questions are answered?
So the first is an examination. That exam is really looking for the hormonal status of that patient. So, you know, we're looking to see what their beard growth is like. We'll evaluate the thyroid. We'll do an exam of the chest, and then we'll do a more personal examination looking at that individual to try to assess kind of the health of the genitals. In doing so, we're also looking for things called the varicocele, which is swelling in the veins that come back from the testicle.
Is that common?
So varicocele is a very common finding. It's seen in about 1 in 8 men. It is not an abnormal finding in any way, but in some men it can affect sperm production. And so, you know, we look for it, and for me that's like a blinking light. When I see it, it's like, okay, I have a target and we have something to go towards. Mm-hmm. After the exam, then very often I'll send that patient for some laboratory studies. So we'll do some blood work. Some men will end up getting a sonogram. And then if we don't have an analysis yet, we'll ask for a semen analysis, which is done off-site somewhere else in the privacy. Sometimes it can be done in the privacy of their own home, depending on halachic issues and different religious expectations. There are a number of different steps that we have to go through, and you know, we work very closely with the rabbinic community to try to make sure that we're doing things by the book in the patients who are seeking that, and to move them forward.
Okay, and then what are some other, besides varicocele, what are some other common findings that lead to male infertility?
So, you know, if we start a little bit earlier in terms of that evaluation, a big one is actually in their medical history up front. And, you know, very often we'll find patients who are on medications that will hinder their fertility. Certain patients who take certain psychiatric medications, they've been shown to have a clear effect on their sperm production. One of the things that I hate to see, but I love to see because I can fix it so quickly, is men who are using testosterone replacement. So, you know, some younger men who've been going to the gym who are trying to build muscle and you know, they say to themselves, okay, I have a little bit of hormone, more hormone's going to help.
Are you saying like a steroid?
So sometimes it could be steroids. In some situations, patients are actually put on testosterone replacement by their doctors, with the question being that, you know, maybe their testosterone is low and that's why they're not getting pregnant. Mm-hmm. Testosterone works the other way. So yes, we need our bodies to make testosterone, but if I start giving testosterone externally, the body then sees that as a message as, oh, I'm making a great amount of testosterone, I can shut the machine down. Uh-huh. So everything stops. And so, you know, we'll see kids in their, I shouldn't say kids, men in their late 20s, early 30s, will come in with a 0 sperm count, and it'll be like, well, what's going on? And, you know, next thing you know, the guy's been on testosterone replacement. You stop the medication, you get him feeling better, and within 3 to 6 months, you're back up and running. So, you know, there's a lot of misinformation out there, and it's on us to help kind of guide people a little bit further, I think.
And what about like unhealthy lifestyle, age, weight, smoking, all of those things?
Yeah, so they all play a very big role. You know, I think certainly there are the things that people do that they know they shouldn't. Smoking is probably the very first target that I will attack. Obesity is a big problem. People who are inactive is a big problem. One thing that I forgot in terms of medication, which is actually much more common than even the testosterone replacement, is men who take Propecia. So, you know, the medication that we take for hair loss.
I'll give you some.
That has also been proven to have a very clear effect on sperm production in some men. And so, you know, it's a total package in terms of what we're looking at.
And then how do you fix a varicocele? I wanted to ask you, I'm sorry.
So I think before we talk about how do you fix it, I think the question is, what does it mean, and how do you kind of approach that question?
Okay, sorry.
And so, you know, I think part of the issue with varicocele is, given the fact that this is a normal variant of anatomy, what we're trying to figure out is, in whom is the varicocele an abnormality? And so there's a few different parts to that picture. I think one of the things that we look at is, you know, certainly when we have a couple who's already proven fertility, you know, you have a couple who's had 2, 3 children, they got married in their early 20s, and now all of a sudden it's been 3, 4 years, they can't get pregnant, or they're having recurrent miscarriages. One of the first places we look at are varicoceles, because varicocele over time can have a deteriorating effect on sperm production.
So you're saying it's an indicator for secondary infertility?
It's actually one of the prime places that we look. Oh. So, you know, when you have secondary infertility, the first question in our mind is there a varicocele in this couple? Uh-huh. Now, that also depends on the age of the couple, right? So, you know, if you have a couple who's getting married younger, you're going to see that as secondary. If you have a man who gets married in his mid to late 30s, he didn't have a chance to prove his fertility before. And so, you know, he may be presenting, and already you're seeing the varicocele effect there. You know, I think for me, the picture is, if I see a semen analysis that has lower sperm numbers, lower sperm motility, in general, that becomes a warning sign that maybe there's a varicocele playing a role here.
Can you take a minute? Numbers, motility, all of that. I think that would.
So when we do a semen analysis, what we're doing is you're kind of taking a 10,000-foot view of the ejaculate itself, and you're getting a sense of kind of what's the health of the sperm in that man. So it's really looking at 4 main parameters. One is the sperm concentration, which looks at how many sperm that man is making. One is sperm motility, which looks at how well the sperm are swimming. Then we look at sperm morphology, which looks at the shapes of the individual sperm. And we also look at volume, which looks at how much of the semen is there that we're evaluating in these men. And so that picture tells us what's the likelihood of that patient's ability to conceive, assuming a normal female factor.
Mm-hmm.
Now, one of the important things to understand about that, though, is that when we look at what the normal semen parameters are, you know, if we say 15 million sperm per milliliter of semen is considered a normal sperm count, that number actually comes from looking at men with proven paternity, where you take 1,000 men who have children, and at the 5th percentile, that was the cutoff. So men who are at 15 million, where it's called normal, where the gynecologist is going to look at this test and say this is a normal sperm count, already have low counts. These are people where 95% of the population who has proven paternity has a higher sperm count. And so, you know, there's a bit of art that goes into it. I think, you know, most people don't have a good understanding of what that means. But the other element of all this is that, again, this is a 10,000-foot view. It's not telling you the health of any one individual sperm. And so, you know, we'll see men who come in, they have low sperm counts, low sperm motility, they have children. Number one, it's the body doesn't work like clockwork. Number two is we have a creator above who plays a role in all of this. And so, you know, you have to understand that nothing that we look at is a be-all, end-all. I never say to people, it can't happen or it's miraculous if it happens, because we don't have control at the end of the day.
So once you tackle the more common causes, lifestyle, hormones, varicocele, once you do our part, do you see natural after that, or do they still need fertility treatment?
So, you know, I think it depends on the couple, and it depends on, part of it is the health of the female partner. Part of it is how much did our intervention help. So, you know, as an example, I had a couple, I just got this call actually yesterday, which actually made my entire day. We had a couple who had come in. The husband had a very low sperm count. I think it was something around 150,000, 200,000 sperm. He had a large varicocele. We did surgery to repair it. And, you know, as is often the case with couples who are dealing with infertility, your patience wears thin. You can't really wait that long. You know, you've already been waiting. It's taken you a year or two to get to me. Then I'm doing a procedure. Then you're waiting another 3 to 6 months to see the benefit. And so this couple, at the end of around 3 to 6 months, they had seen a robust improvement. You know, he had a 10-fold improvement in his sperm count, but it was still only 2 or 3 million. You're not looking at a huge number there.
So that's still considered low?
Yeah, so less than 15 million we'd say is low. So he moved up.
Yeah.
But, you know, it's a remarkable thing. He moved up, but it just wasn't enough.
Okay.
He ended up, you know, as a couple, they proceeded with IVF. Thank God they had a child. It was now 4 or 5 years ago. I got an update yesterday for the first time in 5 years. After that pregnancy, the wife got pregnant 3 times. They have 4 children, natural pregnancies. Probably his sperm counts are, thank God, doing very well. And so, you know, some of it is a timing question. Some of it is some people respond better than others. I think part of it depends on what's the driving force behind all of this, and can you correct something that's truly the source of the issue?
Okay, that's interesting. And what about, like, does your end, I'm trying to figure out how I want to word my question, does it lessen the amount of fertility treatment needed?
So it certainly can. And, you know, I think that's really one of the main things that we look at, which is when you talk about burden of treatment, if you look at how we treat an infertile couple, the options that you have are natural conception. 2 is to do something called IUI, which is intrauterine insemination, where what we do is you take the semen, you wash it, you take the best swimmers, you then inject that into the wife's cervix, and then you let
nature take it.
Nature takes its course. The third option is to do IVF, which is a bit more intensive for the female partner. It requires a series of medications which cause her to make more eggs. Those eggs are then removed from her body, and then outside of the body in a dish, the sperm are placed in a dish near the egg, and then they're allowed to fertilize. And we can also do things called ICSI, which is intracytoplasmic sperm injection, where you take one sperm and you inject it directly inside the egg. So, if we look at these as a continuum, there are a few different factors that go into it. Egg quality goes into it, sperm quality goes into it. And when you have men who have very low sperm counts, very often they're already looking at either doing IVF or ICSI. And so the question can sometimes be, can I reduce the burden of therapy that you have to go through? Meaning, instead of doing a $25,000, $30,000 ICSI cycle, if we do, if we treat you and get your hormones optimized and we figure out kind of what's going on and can improve the male factor, sometimes you can move to IUI, which is far less expensive. And sometimes not.
And far less.
It's far less expensive. It's far less invasive. So, it's just an easier situation for both partners, or God willing, you get to a natural conception.
So really, the male is so important to be done from the very beginning.
Yeah. I mean, it's your job is it's not just in the bedroom. It's if you're not getting there, then you should be looking at it a little bit more closely, I think. And
then so on like the more common causes, could we go to some more serious causes of male infertility and what how you treat them, and after that what happens?
Yeah, so I think when we think about more serious causes, I think that the key question is what is actually at root there. So in some men it could be that they had a previous cancer, God forbid, and therefore they've then received chemotherapy and radiation therapy that may have affected their sperm production longer term. In some people, we have genetic abnormalities where, they're completely normal. They're going to lead long, normal, full lives.
The man, you're saying.
The man. But essentially what we're finding is that he may have had an extra chromosome that he never knew about, which can then affect their sperm production. We have some men who are born without some of the tubing that's required to carry the sperm out from the testicle itself. So that's a normal individual. That's a person who's going to make sperm just like anybody else, but the highway's closed. There just is no way out. And so in those, we kind of look at a different treatment option. I think the key question in couples that are presenting with either severely low sperm counts or a zero sperm count is, number one, is it because of a blockage? Is it that either they're missing the tube, or did they have some kind of infection in childhood that blocked one of the tubes? Did they have a hernia repair which ended up blocking one of the tubes? In that situation, it's a fairly straightforward procedure that we can do to get sperm directly from the source. In other couples, you're looking at a male factor where there's low production that's at issue. And so one of the things that I always tell patients who come to me with a more dramatic semen analysis, the guy who comes in and it says my sperm count is zero, is that zero sperm on the analysis does not mean zero sperm production. And even in men who have have a production issue where the factory isn't working as well as we think it should, very often, in around 55–60% of men, we can find sperm within the testicle itself, which can be used as part of IVF.
And this is done as a surgical procedure?
So that tends to be a bit more invasive. We don't take the decision to go to that very lightly. People who are presenting in that situation usually will do multiple things to try to optimize them up front to get some kind of production to show up without doing that. But when we do get to that point, you're not talking about buying a lottery ticket. I mean, 55–60% is a very real odds that we look at. And so, those are the situations where you look at it and you say, wow, this is miraculous. But, the odds are, if you were seen by an experienced urologist who has experience doing the procedure, you'll have success, and the odds are in your favor. So I tend to be a very optimistic person by nature, but in general, I don't think I'm selling people snake oil when they're coming in. You know, I think we have data behind a lot of the interventions that we do, and it's real and it works.
So are you saying, like, even in the more extreme cases, it's not hopeless to have a baby?
Correct. Yeah. It's, you know, I'll say probably in the last 6 years, I've seen one patient where I've said to them, there's nothing that I can do.
Wow.
Meaning and I remember that guy very clearly because it was the only time that I've ever had to make a statement like that. So I'm not saying we always have success, but I think very often, if you look at odds, there's a chance, there's a likelihood. It's rare that we have somebody who doesn't have a likelihood.
Mm-hmm. Okay, that's I think that that's a very important message because I would imagine that kind of diagnosis is devastating. How do you deal with the emotional impact of that kind of diagnosis while they're sitting and you're giving this not so great news?
Yeah, I mean, I think there's two elements to that. I think one piece of it is very often they've already heard this news from somebody else. And so, you know, it becomes a bit easier on me because they're coming in kind of dejected and expecting nothing. And all of a sudden I'm saying, well, we have these steps that we can take and I have this likelihood that can get you somewhere. And it's for real. Now, in the couple who comes in who's getting a workup with me and then I'm the one who's finding it out, I still pitch this as we have optimism. You know, it's kind of, this is not a stop sign. It's a bump in the road. Usually we can get around that bump in the road. Thankfully, most couples who are presenting to me with accounts like that, I've already given them warning ahead of time, meaning there are signs on the exam that's kind of leading me in that direction. And so you kind of ease people into it a bit. But
Signs that we could be aware of, just I guess as young adults or getting
not really. You know, what's shocking to a lot of couples who come in is, you know, I'll have a guy who comes in and he's 30 years old and they're having trouble getting pregnant. And I turn to him and after some testing, I say, you have an extra chromosome and you were born with 47 instead of 46. These are normal people. So you won't see signs very often. It's just one of those things that you try to get pregnant, you're failing to get there, and all of a sudden you kind of, it's like, well, here I am. I mean, I think for a physician to be able to identify it is different because they're examining more than one person, and you know they've seen patients, they kind of know what to look for. But for any one individual, first of all, that person has grown up like this, so that's his normal.
Right.
And I can't expect that the wife would ever know if something is going to be normal or abnormal unless it's markedly abnormal, you know, unless it's something like, it's like, well, what's going on here? And that what's going on here situation is almost never.
And do you see fighting in your office between, maybe not fighting is the wrong word, distress between husband and wife?
Absolutely. Very often though, I think that the issue is it's more and I don't mean this in a sexist manner. It's often a woman who is so frustrated with how she's been treated that it comes to a head. It's like, well, all of a sudden now it's clear that it's from the husband, and why didn't they send him there, and why aren't you doing everything the doctor's suggesting? Thankfully, though, most of the time that the husband is very understanding of what's going on. And very often the wife will cool down very quickly because I think sometimes people just have a lot on their chest. They haven't had a chance to release this anywhere. You know, you have guilt and you have blame and this and that. And so usually when it comes out, then we handle it together very quickly and the couple then moves on kind of hand in hand. So it's rare. It's not a common thing that we'll see.
Okay. Rachel actually just put it in the chat. She wants to know, are these issues genetic? I guess she means the Rachel, correct me if I'm not understanding, like the varicocele issues and what else? Elaborate.
So they can. You know, varicocele is certainly genetic. Usually, if a man has a varicocele, probably his father had a varicocele. Um, it's normal anatomy at the end of the day. So, a lot of it is based on kind of that person's build. Skinny, tall individuals are more likely to have varicoceles than not. So if you're
Tall. We
say
want
again,
to be skinny and tall.
and a lot of it has to do with the internal anatomy, because those veins actually drain up towards the kidney, and if it has to travel higher, then you'll get a higher pressure. There's a bit of science actually behind that. But skinny and tall tends to also be genetic, right? So if your father was skinny and tall, you will be more likely to be skinny and tall. There are certain there are a group of fertility diagnoses that are certainly genetic. Certainly in certain couples where they have very low sperm counts. I also advise them that their son is likely to have that same condition. So it depends on kind of what the issue is that's playing a role.
So in a situation like that, when you're advising them that their child could run into the same problem, is there any kind of pre-treatment to the child? Like how do you handle that in a family?
So, I use a lot in terms of genetic counseling. So there's an entire field of medicine that's devoted to this, that helps couples to understand what are the genetic effects of something like this. Very often, though, if we're talking about certain genetic abnormalities that will specifically affect sperm production, my answer to that couple is, if you're getting to a son, your son is likely to get to a son also. Yeah, you had a bump, but whatever it is, it's something that's handleable. And to me, it's not really necessarily something that should ever stop somebody from moving forward. I think to get to your question in terms of, some of what you're looking at is, can you figure this out from a pre-implantation genetic diagnosis if you're doing things like IVF, or can we do gene therapies? The gene therapies, we're not there yet. The PGD, which is a specialized test that we do at the time of IVF, can sometimes identify some of these. So you can screen certain embryos in certain places.
Okay. So what else? What else is important? Other messages you have to people who are beginning the process, the middle of the process? What did we miss in our conversation? I stumped you.
I think that the issue is it's a big topic, and I think really what my objective here is for people to understand that, number one, a lot of the issues that are leading to this are actually common, and so it shouldn't be assumed that, hey, I'm never going to deal with this. And then even in those situations where it's less common, we very often have treatments that we can administer. But it also matters who you see. There are certain doctors who don't have as much experience, who don't necessarily believe in some of the data that's out there. I've seen patients who've been seen by urologists where they're diagnosed with a large varicocele. The urologist says to them, varicoceles are normal, you don't have to do anything about it. And it's not that that's a bad doctor. There are physicians and there are studies out there that may say that. But I think as you do this more and more, and as you see the dramatic improvements that some people can have, it becomes important that that male goes to see somebody who has experience, who's done this for a while, who kind of can see some of the angles that are within it.
And you, Mrs. Haber wants us to touch more upon your relationship with fertility specialists, which is a great point, because you mentioned in the beginning that they were your gatekeepers.
Right.
So once you get the couple in your care, what is your relationship like with her doctor?
So we actually work very closely and hand in hand with the female teams very often. I have very close relationships with a number of the IVF groups, probably most of them in and around Manhattan, as well as some of the groups in Brooklyn at this point. It's a team approach. Again, if you're looking at that, the couple is one unit. So, for me to sit there and pretend that the female factor doctor doesn't exist and to be possessive and to say, I'm going to do my surgery and I'm going to move forward. We're not getting to the goal. You know, I can find something in the male factor, and if there's something from the wife's perspective that's also playing a role, maybe I didn't need to treat that. You know, this has to be a cohesive unit. We're working as one team. And, you know, humbly, most of these doctors have my cell phone number. Very often we're in contact with each other very closely, whether it's with letters, emails, phone calls. So, you know, you really need people who are going to be working closely with one another.
Okay. We have some questions coming. Guys, I see some questions through the chat, but it's hard to follow. So if you could put the questions, I have a bunch already in the question box. And if I missed anything important that you want to ask, please send them that way. It now.
There was one question that I saw in the comments about low testosterone and its effect.
Okay.
So the answer to that is yes, it certainly can affect. And we do have other ways of improving testosterone. But again, using testosterone replacement is not the answer. So that's, you know, we've been focusing on some of the other treatments, but really one of the first places we look at is at that patient's hormonal status. And that's the easiest place to start is, you know, do we give medications to help improve their hormone production, which can then help nourish better sperm production. So low T is actually one of the first places that we will look in couples who are coming in.
Okay. Let's see what else we got. Can you explain much lifestyle, fertility, and one of the examples she asked specifically about was e-cigs?
So, you know, I think substance abuse in general, whatever that substance is, and nobody likes hearing this as a term substance abuse, but number one, smoking has to be out. We know there's a very clear relationship in terms of fertility from that. Marijuana smoke, even more of an effect. So I tell people to abstain completely from that. You know, the question of e-cigarettes is not 100% clear yet. You know, if the question is, I have somebody who's smoking actual cigarettes and they're going to downgrade to e-cigarettes as part of a stepwise thing to get to quit, fine. But if you're smoking e-cigarettes and you can stop, stop. You know, I think really the idea is we're trying to get rid of anything that may have any kind of effect here.
And once you cut those habits, do you see a rise in sperm count, or it's like damage done?
It depends. You know, I have some patients in other communities who come to me. They'll come with a near zero sperm count. The guy's been smoking marijuana daily for weeks and months and years. You stop it 3 to 6 months later, you'll see a dramatic improvement.
Wow.
I've also seen men who come in with much more, their habits are actually better for their life and for their general health. You know, patients who will take certain diets on to try to lose weight, they're trying to bring down their blood sugars, but they'll go to an extreme unintentionally. I've seen patients who have proven fertility where the sperm count will decline dramatically. And just with changing the diet and having a more balanced diet and adding some moderate exercise, we'll get to a place where they're back to normal. So, you know, it's a total package. I think the other element of this is we always tell people, reduce your stress, reduce your stress, reduce your stress. You tell somebody to reduce their stress goes up.
Exactly.
So it's not a possibility, but, you know, I think that there are certain things that you can do, you know, whether it's exercise, diet, trying to find more time to rest, but, you know, we're trying to treat the whole package.
I want to just touch on exercise for 1 second, because there's always a... Can you clear that?
So I missed half of your question. Can you repeat it for me?
Yes, I want to touch, you said exercising. So there is, I mean, I've heard it a million times. There's always a myth about bike riding affecting sperm count. Can you clear that?
So, you know, the bike riding probably does not have any effect on sperm count. It may have an effect on other functions in the bedroom. And it depends on how intensely and intensively that person is on the bike. In general, 30 minutes, 3 to 4 times a week, no matter how hard it is going to be fine. But, people who are coming in and they're training for triathlon and they're running 3-4 hours a day, that's not going to be good for you. Your body goes into, I'm going to build muscle and I'm going to survive rather than let me make sperm. And so, we try to moderate.
Okay. Let's go back to our questions. A few more pop up. Anything men can do to enhance fertility, diet, exercise, vitamins, or others? So we definitely said diet, exercise. Any vitamins?
So there are some supplements that are out there. And my viewpoint on supplements is a simple one, which is it may have a marginal benefit. I think these supplement companies are multi-million-dollar businesses. Very often you don't know what's in that supplement itself, so you need to have a reputable manufacturer. But the truth is, if these were for real and they were proven and they had a dramatic improvement, it would be a multi-billion-dollar business, meaning the whole world would be taking these. This would be kind of first thing, top of mind, commercials everywhere. So there's no one dramatic fix. I tell most couples, if the $50 a month is not going to be a significant drain to you and it's something that you want to do, go ahead. Do I think that you need to? I don't. And so I give people recommendations and I take my hands off at that point.
So someone actually just put an interesting question in the chat. We had mentioned before about medicines that were taken in the past that could have affected male fertility. So she wants to know if medicines that were taken for health issues that might have caused damage, is there still a chance afterwards for healthy sperm production?
So the answer to that is generally yes, but it also depends on the medication. So the one place where that may not be the case is in, God forbid if we have a younger patient who's undergoing cancer treatment, some of those chemotherapies can have a permanent effect. But even in those couples, we can consider doing sperm retrieval surgery, which will succeed in a reasonable percentage of those men. Outside of that picture, for the most part, most medications that people take, you stop it and you come out of it.
Mm-hmm. Okay, let's go back. We got a few more. 1 second. Do you recommend men coming to check everything out before marriage or trying just to prevent finding out anything too late? I can't read the rest. It's a very long question, and it's cut off. So I think what she's asking is, do you recommend people doing like workups from beforehand or just waiting until the canary hits the coal mine?
Yeah, so I don't necessarily think that a young man who's due to get married needs to come to see a urologist for an evaluation. I think certainly most boys have been seen by their pediatrician, and as long as they've done a realistic examination, there isn't much farther that I would go. I struggle with this question. The truth is, fertility is going to affect something like 12% of couples. But I don't think that adding this into the picture when a couple is due to get married is going to help anything. I think it leads to more stress. It's not a proven thing.
It's kind of like a buzzkill.
It's a huge buzzkill, number one. Number two is, how far can your testing really go? If you have an unmarried couple, depending on kind of religious preference, there's only certain tests that you can do. Those tests are not definitive. I generally try to steer clear of it unless there was something earlier that was a warning sign. So I tend to push that away. Some of that is a faith issue from me. It's, I have trust that things are right and you kind of move forward, but I generally don't move in that direction.
Okay. So we have a ton. Hold on, let me just finish reading them. We have a ton of questions on COVID and the vaccine. And I know we spoke about this earlier, you and me, and you and I.
And we tried to avoid this question.
But but I can't ignore like 10 people. Dr. Berookhim didn't really want to discuss it, but can you tell us why you don't want to discuss it?
Yeah. So, and I think the issue is a simple one, which is we know already from long ago that patients who have febrile illness and patients who are critically ill in any way, it will affect their sperm production at least in the immediate term. You know, I was asked to comment on a study that was recently published looking at men in Italy who were exposed to COVID, and they showed a very clear study that said these men had lower sperm counts as a result of this. But if you looked at the data, those men were in ICUs, on ventilators, very, very sick. And so was it the COVID? Was it the fact that they were very sick? Was it all the medications they got in the ICU? Was it the 100 other things that was going on with them? Probably it was everything else. You know, it's not clear that it's necessarily COVID there in that situation. There is a question with COVID as to whether or not there's a receptor within the testicle itself which it approaches. I myself have seen a number of couples who come in where after a COVID diagnosis there's been a decline.
Oh.
Usually that does improve. So usually over the course of 3 to 6 months, as the body clears it, that improves. Now, the answer to the next question is, I've only seen this for 3 to 6 months, right? Because everybody was in quarantine, and then people are starting to show up, and now we're starting to see people coming out of it. So can I say everybody comes out? I can't. You know, I think that the bigger issue is we just don't have the all the data in hand yet. With regard to the vaccine, same issue. We don't have the data in hand, but I will tell you, I am telling my patients, go ahead and get a vaccination. We don't have any plausible issue to assume that the vaccine is going to be affecting their fertility. Even in couples who are trying immediately, I tell them that they should probably get the vaccine.
Okay. Popped up in the chat. Any hope after the male's unsuccessful surgery? So we discussed a few problems that were solved by procedures, but what happens when they're not solved?
So, you know, it depends on a couple of things. One is it depends on what the source of the issue was. Two is sadly it depends on the quality of the surgeon. So I published a study a few years ago looking at men who had come in with a 0 sperm count due to poor production, who had had previous testicular surgeries, and in some cases they had had 2 previous testicular surgeries that had failed, and in 40% of those men we were finding sperm. So it depends on the quality of the surgeon and on the quality of the surgery that they had done. Now, I think if that couple has gone down that road and they've seen a reputable, well-known surgeon who's doing this, then sometimes we start thinking in terms of other avenues, whether it's adoption or things of that sort. But that's rare. That's uncommon that we're looking in that direction.
Okay. Let me. Things popped up.
Dr. Simpson.
Sorry, just give me 1 second. I think 2 more questions popped up, but I'm going through them. Somebody wants to know, why does everything take 3 to 6 months? It seems like that's your magical number, not yours, but you know,
yeah.
The magical number to see improvement.
Yeah. So that's a great question. And the reason for that is sperm production takes around 75 to 90 days. So any intervention that I'm going to do, I'm going to see the benefit of that 3 months later. So similarly, if I do something harmful, that harm is going to be seen 3 months later. You know, if I start somebody on testosterone replacement tomorrow, for the next month, he will probably still have a normal semen analysis. But 3 months later, that number is going to be 0. And so, you know, when you say 3 to 6 months, it's really, you're looking at 2 spermatogenic cycles. That's when you first start seeing the curve improve.
Mm-hmm. Okay. Okay, so what's the name of this doctor? Everyone, this is Dr. Berookhim. Do you want to introduce yourself again?
So I'm Bob Berookhim. I'm the director of male fertility and microsurgery at Lenox. Born in New York, raised in New York. Did most of my training here in New York. Happy to help with anybody. And and would be happy to discuss with anybody who would want to come in.
Okay, so thank you so much for joining us today, giving us an education. This is, I'm sure, just the tip of the iceberg, but it's so important that everybody gets some knowledge as to what could be going on, and things that they should be on the lookout for, especially when they are starting their fertility journey. SBH Fertility is always here to help you and guide you. We have a tremendous amount of resources, one of them being Dr. Berookhim, amongst many other urologists and fertility doctors, geneticists, nurses, psychologists, social workers, and we are always here to guide you if you are ready to reach out. And put in our number, 787-1100, extension 517. And Dr. Berookhim, I cannot thank you enough for joining us tonight. You're amazing, and you're so kind, and you're so patient. And guys, I stalked him, and he didn't even flinch.
If you call that stalking, you haven't seen anything. So I think we did okay. I appreciate it. And this, I think for me, it's to work in a community that's close to home for me is probably one of the most important things. And this, believe it or not, it's a labor of love. It pains me to see all the disinformation out there, and I think especially within this group, anything we can do to help. And so it's my privilege, and I'm humbled by the opportunity to do so.
It really shows that you're humbled. So many times you spoke of fate and believing in above, and that it's your guiding light.
Yeah, no, I mean, I don't know how much I should be, but we've got no control over anything. It's our job to fix the parts that we can fix, and then we have a partner upstairs, and so we work together with that partner and see what we can do.
You're very hopeful and encouraging. Thank you so much.
My pleasure.
Have a great night.
You too.